Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal.
In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy.
This episode reviews the article titled Systematized Review of Acne vulgaris as a Systemic Metabolic Disease,
Authored by researchers Meji Inishvili and Professor Salome Galanti, published in March of 2026.
So what if the pimple on your cheek has more in common with your blood sugar levels than it does with, the actual dirt on your face?
Right, which is a wild thought.
It really is,
Yeah.
because for decades, we've treated acne like a strictly surface-level problem. I mean, the common advice is always just wash your face more diligently, maybe apply a harsh drying cream, and just wait for it to clear up.
Yeah, just scrub it away. But this massive review of medical data suggests we might have been looking at this entirely backward. We've been intensely zooming in on the visible symptom while completely ignoring the metabolic engine that's actually driving it from the inside.
Welcome to the Deep Dive. I'm your host, and joined as always by our resident expert. Today, our mission is to figure out if acne is truly just a skin-deep issue, or if it's actually a reflection of the body's entire metabolic environment.
And we are pulling our insights today from a remarkably comprehensive, systematized review.
Yeah, the sheer scale of this research is what makes their conclusions so compelling. I mean, the authors didn't just look at a handful of, localized short-term trials.
No, not at all. They synthesized evidence from multiple major scientific databases, spanning from January 2000 all the way to March 2026.
Wow, so that's over a quarter century of data.
Exactly. Over 25 years of data, all aimed at cutting through the noise to see the big picture of what is actually happening inside the bodies of people who suffer from severe or persistent acne.
Okay, let's unpack this, starting with how we have traditionally understood the science of a breakout and why looking at 26 years of data forces us to fundamentally change that narrative.
Right. So the standard medical view of acne, specifically acne vulgaris, which is the form most people experience, it centers on this microscopic structure called the pilosebaceous unit.
Oh, the pilosebaceous unit. I mean, that sounds incredibly industrial. What exactly is happening inside a pilosebaceous unit?
It's a great word, isn't it? It essentially functions as a tiny biological factory located just under the surface of your skin. It consists of a hair follicle and its accompanying sebaceous gland.
Okay, and that gland makes oil, right?
Exactly. That gland's primary job is to manufacture sebum, which is a natural oil that travels up the hair follicle to keep your skin lubricated and waterproof.
Makes sense.
But traditionally, dermatologists point to 4 distinct malfunctions in this little factory that end up creating a blemish.
Let's break those down. What is, the first domino to fall?
The first is localized androgen activity.
Meaning hormones.
Right, androgens are hormones, and when they stimulate the sebaceous gland, it starts working harder. The second malfunction is a biological process called follicular hyperkeratinization.
Okay, hyperkeratinization. That is a heavy piece of jargon. What is actually happening at the cellular level there?
Think of it as a biological traffic jam.
Oh, I like that.
Yeah, so under normal circumstances, your skin is constantly shedding dead cells, to make room for new ones. But with hyperkeratinization, the dead skin cells inside the follicle become incredibly sticky.
Gross.
Yeah, they refuse to shed and exit the pore naturally. Instead, they just clump together and completely plug up the exit route.
So you have a blocked exit, but the oil factory underneath is still running.
Exactly. Which naturally leads to the third issue, which is sebaceous gland dysfunction. The gland just goes into overdrive and pumps out an excessive amount of oil.
Wow.
So now you have a flood of sebum trapped directly behind that roadblock of dead, sticky skin cells.
And I imagine that trapped, oily, oxygen-deprived environment is pretty appealing to bacteria.
Oh, that operates like an all-you-can-eat buffet. Which brings us to the fourth malfunction, the microbial imbalance. The bacteria that naturally and harmlessly live on your skin suddenly get trapped behind the plug. They feast on the trapped oil, multiply at a rapid rate, and trigger your body's immune system.
And the immune system attacks.
Yeah, your body sends inflammatory white blood cells to fight the bacteria, and the visible result is a swollen red pimple on the surface.
That sequence makes total sense. I mean, it perfectly explains the mechanical steps of how a blemish forms, but treating just that sequence with like topical face washes, it feels a bit like painting over a water stain on your living room ceiling without ever going upstairs to fix the leaky pipe.
That is a perfect analogy.
Right, because you might make the ceiling look fresh for a week, but the underlying pressure is still there and the water is just going to come right back through.
And that is the pivotal shift the researchers make in this review. By zooming out and analyzing decades of data, they found overwhelming evidence that systemic metabolic disturbances are the leaky pipes.
Meaning things outside the skin entirely.
Exactly.
Yeah.
Meaning what is happening with your blood sugar processing, your circulating hormones, and your fat storage. They are major players in determining just how severe and how persistent that acne gets.
I want to challenge this concept, though.
Sure.
If the issue is a systemic metabolic storm, say, my blood sugar and insulin are totally out of whack, why does the acne usually only show up on my face, my chest, or my back? I mean, if my entire body and bloodstream are experiencing this metabolic crisis, why isn't the symptom everywhere?
That is a fantastic point of skepticism. The answer lies in how human biology distributes hormone receptors.
Okay.
The sebaceous glands located on your face, chest, and upper back have a uniquely high concentration of androgen receptors compared to the rest of your body.
Oh, interesting.
Yeah, so even though the metabolic storm is flowing equally through your entire bloodstream, those specific areas act like lightning rods. They are highly sensitized to catch the hormonal signals that the skin on your arms or legs might simply ignore.
That makes perfect sense. So with this whole body view in mind, are the authors suggesting we rewrite the medical dictionaries? Like, if the root cause involves blood sugar, is acne actually a metabolic disease like diabetes?
This raises an important question, and the authors are very careful to address it directly so their findings aren't misinterpreted. Their stance is clear.
Yeah.
No, acne should not be reclassified as a metabolic disorder.
Okay, so it's still a skin issue.
It fundamentally remains a dermatological disease. However, its severity, its persistence into adulthood, and its stubbornness to resist standard clinical treatments are heavily influenced by systemic metabolic processes.
Got it.
You don't have a systemic disease, but a systemic environment is heavily aggravating your skin disease.
So if the skin is just acting as a warning light on the dashboard, what is actually misfiring under the hood? Looking at these 26 years of data, it seems the engine trouble almost always starts with how the body handles sugar.
Yeah, the sugar-skin connection is undeniably the most consistent finding in the entire review. Across varied populations and, different study designs, the researchers found a highly reliable link pointing straight to insulin resistance and glucose metabolism abnormalities.
Which is wild because for a very long time, the idea that diet-affected acne was brushed off by the medical community as like an old wives' tale.
Oh, completely.
People were told that eating a candy bar doesn't cause pimples. End of story.
Right. And a single candy bar isolated in an otherwise healthy diet might not. But living in a chronic state of elevated insulin absolutely changes the physical environment of your skin.
How so?
The mechanistic studies highlighted in this review map out the exact biological cascade, and it is fascinating. It starts when a person develops insulin resistance, meaning their cells stop responding efficiently to the insulin trying to deliver energy.
Right.
So to compensate, the body starts pumping out higher and higher levels of insulin just to force the blood glucose down.
And what does that flood of extra circulating insulin do once it hits the bloodstream?
Well, high insulin levels directly trigger the liver to produce more of a hormone called IGF-1, or insulin-like growth factor 1.
Okay.
And as the name suggests, its primary job is to signal your cells to grow and multiply. But more importantly for our skin, IGF-1 activates a specific signaling pathway inside your cells known as mTORC1.
Okay, mTORC1. Let's slow down and break that down because I know that specific pathway plays a massive role in how human cells process nutrients and energy.
It does. Think of mTORC1 as the general contractor of your cellular construction site.
I like the analogies today.
Thanks. It constantly monitors the environment to see if there are enough building materials and energy available to grow. When insulin and glucose spike, it's like delivering a massive shipment of bricks, steel, and lumber to the site.
So the contractor gets to work.
Exactly. mTORC1 sees all this abundant material and yells, "Start building."
And in the context of those lightning rods on our face, what exactly is the contractor building?
It forces the sebaceous glands to physically grow larger and manufacture massive amounts of excess oil. But the biological cascade doesn't stop there. That same initial spike in insulin and IGF-1 does something else simultaneously. It reduces the liver's production of a specific protective protein.
This protein is sex hormone binding globulin, or SHBG.
Yes, SHBG is absolutely crucial for keeping our circulating hormones balanced and safe.
Wait, let me make sure I'm visualizing this correctly. Is this protein basically acting like a chemical taxicab for hormones? Like it picks them up and drives them safely through the bloodstream so they don't cause trouble?
That is a brilliant way to picture it. SHBG binds to hormones, particularly sex hormones like testosterone. When a hormone is riding in one of these taxicabs, it is rendered temporarily inactive.
It's just sitting in the back seat.
Exactly. It cannot interact with your cells or trigger any changes.
Mm.
But when chronic insulin spikes force your liver to stop producing these taxicabs, you suddenly have a massive crowd of hormones just running loose in the bloodstream with nowhere to sit.
So these become what researchers refer to as free androgens. They aren't bound to anything, so they are highly active and looking for a place to land.
And remember those lightning rods we just talked about? The highly concentrated receptors on your face and back?
Right.
Those free androgens crash directly into those specific receptors, revving up the oil glands even further and driving highly aggressive inflammatory immune responses.
Here's where it gets really interesting, because for the listener, this translates into a really profound realization about their daily habits.
Yes.
This essentially means that a highly processed, high-sugar meal isn't just giving you a temporary sugar crash a few hours later.
No, not at all.
Biologically, it is setting off a multi-day chain reaction. The insulin spikes, the taxicabs disappear, the free hormones flood the skin receptors, the oil production ramps up under the command of mTORC1, and then days later, boom, the painful inflammation hits the surface. Does this essentially mean that a spike in blood sugar or insulin is literally flipping a chemical switch that pumps more oil onto the face?
That is the precise physiological reality the data confirms. High insulin lowers the SHBG taxicabs, which raises the free androgens, which, combined with the mTORC1 construction crew, forces the poor into a state of total dysfunction.
Wow.
It is a perfect internal storm for severe acne, all originating from how your body processes simple carbohydrates.
That completely reframes how we have to think about a breakout. The call is quite literally coming from inside the house. But if insulin paints such a clear, direct picture, what about other metabolic factors? Does carrying extra weight or having high cholesterol flip similar biological switches?
Well, you're entering what we might call the messy middle of the research. The investigators spent a lot of time looking at altered body composition and cholesterol levels, but the findings over the last 26 years are incredibly varied and much harder to pin down.
Let's start with body composition. I noticed the review explored obesity, but the data seems pretty scattered. Why would insulin be so directly linked to acne severity, but a metric like body weight be so inconsistent across these global studies?
The inconsistency exists because fat tissue behaves very differently depending on the individual. For a long time, medical science thought of fat as just inert storage, like a biological savings account holding calories for a rainy day.
Right.
But we now understand that adipose tissue fat is actually an active endocrine organ. It secretes its own unique hormones, which are called adipokines.
So fat is actively sending out chemical signals and instructions to the rest of the body.
It is deeply communicative. In some individuals, excess fat tissue secretes a heavy amount of pro-inflammatory adipokines. This creates a state of chronic, low-grade systemic inflammation throughout their entire body, which absolutely makes any existing skin inflammation worse.
So why doesn't every single study show a direct link between higher weight and worse acne?
Because not everyone with excess body fat has that exact same highly inflammatory signaling profile. Some people have very different metabolic and immune responses to carrying extra weight. What's fascinating here is how the researchers handled this ambiguity in the data.
How did they handle it?
They didn't force a neat conclusion where there wasn't one. They highlighted this heterogeneity to show that weight alone isn't a reliable predictor of severe acne. It is the specific inflammatory signaling that actually dictates the skin's response.
We see a similar kind of messiness when we look at the data on cholesterol, right? Because the review notes that abnormal lipid levels are frequently reported in severe acne populations, but there's a huge catch to how that data was collected.
A massive confounding variable, yes. Think about how modern dermatology treats the most severe, cystic, scarring cases of acne.
We use heavy-duty prescription medications, things like oral isotretinoin, commonly known by brand names like Accutane.
Right. And a highly common, well-documented side effect of taking those heavy-duty retinoid medications is a significant alteration in your blood chemistry. Specifically, the medication itself can cause your cholesterol and triglycerides to spike dramatically.
Ah, I see the problem for the researchers. If you are looking back at a group of patients who have severe acne and you notice they also have high cholesterol, it's a total chicken and egg scenario.
That is the core dilemma. Did the underlying metabolic issue of high cholesterol somehow drive the severity of the acne? Or did the medication prescribed to treat the severe acne cause the high cholesterol?
Wow.
Because of the methodological variability between all these different studies over 2 decades, it is incredibly difficult to untangle that knot and prove causality.
Which brings up a really crucial nuance from the review regarding metabolic syndrome. We hear that term thrown around a lot in health, longevity, and fitness circles.
Yes, and the authors make a vital clinical distinction here. To be formally diagnosed with metabolic syndrome, a patient typically needs to exhibit a specific cluster of conditions occurring simultaneously.
Like what?
High blood pressure, elevated blood sugar, excess body fat around the waist, and abnormal cholesterol levels. You need the whole combination to meet the criteria.
So what did the review conclude about this full-blown syndrome's relationship to skin health?
They found that while individual isolated components like the insulin resistance and elevated IGF-1 we discussed are heavily linked to severe acne, the evidence linking acne to a formal, full-blown metabolic syndrome diagnosis is surprisingly weak.
You might have the leaky pipe of insulin resistance causing water damage, but you don't necessarily have the crumbling foundation of the entire syndrome.
Exactly. The relationship with the formal syndrome remains insufficiently established, even if specific metabolic pathways are clearly wreaking havoc on the pilosebaceous unit.
Let me play devil's advocate for a moment on behalf of traditional medicine. If the links to obesity and full-blown metabolic syndrome are this murky, and the cholesterol data is tangled up by medication side effects, why should a dermatologist bother looking below the neck? Wouldn't it be easier, and maybe more scientifically rigorous, to just stick to treating the skin directly?
That is the exact pushback many traditional practitioners might offer. Why complicate a standard 15-minute dermatology appointment by dipping into endocrinology and nutrition? But this is where we have to look at the practical clinical implications.
Yeah.
The real-world so what of synthesizing 26 years of data.
So what does this all mean? For the patient sitting on the exam table feeling incredibly frustrated by their stubborn skin.
It means that ignoring the internal metabolic environment is failing the patient. The data on full metabolic syndrome might be murky, but the data on insulin, growth factors, and the loss of those SHBG taxicabs is crystal clear. The researchers conclude that this massive body of evidence supports an urgent shift toward an integrated dermatological approach.
What does that integrated approach look like in practice? Does it mean every 14-year-old who gets a pimple before graduation needs a comprehensive, expensive metabolic blood panel?
No, and the authors are very careful not to overprescribe unnecessary testing. Most teenage acne is transient, hormone-driven, and responds perfectly well to standard topical care.
Okay.
The integrated approach is specifically targeted at high-risk profiles.
What defines a high-risk profile in this context?
Dermatologists need to start investigating metabolic factors when a patient presents with severe acne, or acne that persists well beyond adolescence into their 20s and 30s. It also applies to patients whose skin is highly resistant to standard treatments like antibiotics or topical retinoids, or those who show obvious signs of wider hormonal imbalance.
Like patients dealing with polycystic ovary syndrome.
Exactly.
So if a listener has been prescribed 3 different topical creams, completed multiple rounds of oral antibiotics, and their skin is still aggressively breaking out, that is the blinding red flag that the leaky pipe is internal.
That is the exact scenario where the traditional model fails. For that patient, simply prescribing a 4th, slightly stronger topical cream is ignoring the physiological reality of what's happening inside their body. They don't need another surface treatment. They need an evaluation of their fasting insulin levels.
They might need to address the construction crew, the mTORC1 pathway, by changing their dietary habits to lower their glycemic load and stop the excessive oil production at the source.
If we connect this to the bigger picture, the review serves as a powerful call to action. The authors stress that the scientific community still needs more longitudinal and interventional studies to firmly prove causality.
Meaning they need to prove that actively fixing the insulin resistance directly clears the acne in a controlled clinical trial setting.
Exactly. But we can't just sit on our hands for another 26 years waiting for perfect intervention data when the biological pathways are already mapped out this clearly.
Right.
The current mechanistic data is more than strong enough right now to completely rethink how we manage moderate to severe cases. It is about treating the whole patient and recognizing that the skin is often a very public billboard displaying a private internal metabolic state.
That really brings us full circle on this journey. We started our deep dive at the very surface, looking at a single clogged pore, sticky skin cells, and the bacteria trapped inside. But as we followed the data through the pilosebaceous unit, we eventually traveled past the skin entirely.
Yeah, we uncovered a complex metabolic engine running underneath, driven by insulin resistance, IGF-1 growth signals, and systemic inflammation.
We moved from managing a localized symptom to understanding a systemic root cause. And for you listening, whether you are intensely curious about how human biology connects or you are actively trying to decode your own health struggles, this deep dive proves a fundamental truth.
Which is?
The human body simply does not operate in isolated silos. What happens in our blood sugar pathways, what happens with our cellular nutrient sensors, can and does manifest visibly on our face.
You cannot separate the external organ from the internal organism.
Which leaves us with a provocative thought to end on today. We've established that the skin can act as an early warning system, a literal flashing dashboard light for underlying metabolic dysfunction like insulin spikes and lost hormone taxicabs. So if we look beyond just acne, what other surface-level symptoms in our lives are we ignoring? Maybe it's unexplained fatigue, sudden sleep issues, or chronic brain fog. Are we currently treating those with superficial band-aids while completely ignoring the struggling metabolic engine underneath?
It is a question that demands we look a little deeper at every symptom we experience.
It really does. Thank you for joining us on this deep dive. Stay curious, keep questioning the surface-level answers, and remember that the best knowledge is the kind that helps us see the world and our own bodies a little differently. Thank you for listening to the GMJ podcast.
For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description.
We look forward to continuing these scholarly discussions in future episodes.